I'm Dr. Jeffrey Moon. I'm an emergency medicine physician at Penn Medicine in Philadelphia. I worked an evening shift last night and I had a STEMI case, a stroke outside the window, a stab wound victim, but I also saw a mid-acuity ESI-3 rash that I didn't know what they had. We see it all the time and it changes over time. And today, we're diving into an important and timely topic, measles, on how to identify and manage measles outbreaks. This discussion is especially critical as measles continues to become and emerge as a serious public health concern. I'll also be sharing details about an important collaboration between ACEP and Visual DX to provide ACEP members with cutting-edge technology to help identify and contain measles effectively. I personally would have trouble picking up a morbilliform rash as a busy ED doc. I'm sure some of my colleagues would too. So having software extenders like Visual DX is critical. So I'm thrilled to introduce Dr. Zachary Most. Dr. Most is an assistant professor in the Department of Pediatrics at UT Southwestern Medical Center. He specializes in pediatric infectious disease. He's here to break down the current measles outbreak and most importantly, help us as ED docs to recognize the clinical presentation, take action to prevent the spread in our hospitals and healthcare settings. So Dr. Most, over to you.
Thank you so much for the introduction, Dr. Moon, and thank you everyone for joining this webinar today. As I've been talking with a lot of colleagues locally and with this national audience now, I do feel strongly that our first defense against the measles resurgence is communication and getting the word out and trying to get all physicians, emergency medicine and elsewise to be familiar, to be able to recognize measles when it's around. Got no conflicts of interest to disclose. So the objectives of today's webinar are to describe the method of transmission of measles virus and how to prevent infection, review the clinical presentation of measles and how to diagnose infection, including lots of images that were provided by Visual DX, and review methods to prevent measles infection in healthcare settings, and how to keep healthcare workers and patients safe. So briefly, just to discuss some of the epidemiology of measles, because I think it's important to understand what we're up against here. Measles is a highly contagious respiratory virus. It is transmitted primarily through the airborne route. And so tiny droplet nuclei are produced by somebody with measles, usually by coughing. And these nuclei are so small, they don't get carried to the ground by gravity. Instead, they get suspended in the air, and they can fill the entire volume of the room that they're in. And they can remain infectious and suspended in the air for up to 2 hours, even after an infectious individual leaves the room. This is part of what makes measles so contagious. Some of the important highlights of the transmission dynamics of measles include the fact that there is a relatively long incubation period, especially compared to other respiratory viruses. The incubation period for measles, which I have in red here, is usually about 10 to 14 days, about 10 days or so before the prodromal symptoms start, and usually about 14 days before the classic rash starts. So when someone does get exposed to measles, they will not typically show symptoms for close to 2 weeks after that exposure. People with measles are infectious from the time they have the rash until 4 days after, but also about 4 days before the onset of rash. And measles can be very difficult to diagnose before that rash occurs, and the symptoms look a lot like other respiratory viral illnesses, which is another factor that makes this disease very difficult to control when it's spreading. The attack rate of measles in this setting, if you have a room of people who are all exposed to someone with measles and all of them were susceptible to it, about 90% of them will develop measles. And another way of measuring how contagious this disease is the basic reproductive number, which is a term in epidemiology used to describe if nobody had immunity to measles, how many secondary cases are expected after one infectious case. And this varies depending on where you are and what population you're in, but is usually estimated to be around 12 to 18, making this one of the most contagious viruses that we know of. While measles may be rare or less known in the United States, it remains a threat globally in many places where the disease has not been eliminated. First, here I'm showing data from the WHO of global measles cases in 2000, broken down by each country. And then now I'm showing in 2018, and highlighting that there are lots of areas in the world where endemic measles and outbreaks still occur quite commonly, including sub-Saharan Africa, North Africa, the Middle East, Eastern Europe, and areas of the former Soviet Union. This, you have to be aware of people who are traveling, especially recent travel from areas that could be measles endemic. It's also, again, easy for us in the United States to think that measles is a disease of the past, but it has remained very much a disease of the present and causing serious morbidity and mortality all around the world. In 2023, it is estimated that there were over 100,000 deaths in the world that were attributed to measles. This is similar to a virus like RSV in terms of the amount of morbidity that it causes. There was only one death in the entire region of the Americas, which is North and South America, in 2023, something that we've already surpassed in the United States alone in 2025. Prior to 1962, measles was an extraordinarily common disease in the United States. Virtually everybody was infected with measles in childhood. There were an estimated 3 to 4 million cases per year, nearly 50,000 hospitalizations, about 1,000 severe encephalitis cases, and 400 to 500 deaths every year associated with measles. And this all changed after the introduction of the live attenuated measles virus vaccine, which was first licensed in 1963. And then the combined MMR vaccine with a couple of other live virus vaccines was licensed in 1971. And after that, we really saw a dramatic decline in measles cases. And it was all attributable to the rollout of this vaccine. There was still occasional outbreaks, including a rather large one in the late 80s and early 90s. Eventually, a second dose of MMR vaccine was recommended as part of the routine schedule. And after that, the United States achieved elimination status in 2000. Elimination meaning that there was no sustained transmission within the US, but that doesn't mean that there were no cases. If we zoom in on the post-elimination phase, we can see this chart here. And I want to highlight, I'm going to go back to the other slide, just the difference in the scale in the number of infections that we're seeing. The y-axis here went up to 600,000 when we include the pre-vaccine era. And now when we look in the post-elimination era, we're looking at a scale of up to only 1,400. But even in the elimination era, we do see occasional cases of measles in the United States. They're mostly imported from people who caught the virus in other countries, with some limited secondary transmission. There have been a couple of notable outbreaks in the US during this period, including a 2014 outbreak that started in Disneyland in California, and a 2019 outbreak that involved populations in New York City. Note here that the data for 2025 is already out of date. There's been over 500 cases detected in the US this year. And you can check these data that are updated routinely on the CDC website, where they keep track of measles outbreaks. MMR vaccine is the only effective way to prevent measles. The routine vaccination series, as recommended, is to give dose 1 between 12 and 15 months old, and dose 2 between 4 and 6 years old. About 93% of people will get permanent lifelong immunity from the first dose of vaccine. The second dose of vaccine is not a booster. It is intended to capture some of that population that did not respond to the first dose of the vaccine. And if you immunize the whole population with 2 doses, about 97 to 98% of the population ends up with permanent lifelong immunity to measles. MMR vaccine is safe to give as young as 6 months old. It's just not as effective because maternal antibodies to measles are often present in children of that age, and that would inactivate the virus that is the live virus that's in the vaccine, and then prevent the immune response from happening, which is why we don't routinely recommend vaccine until 12 months of age. But you can give the vaccine down to 6 months in certain high-risk patients to give them whatever additional protection you can. And that includes prior to international travel, during outbreaks. But notably, this dose would not count towards the routine series, and that child would still need 2 doses of MMR vaccine. And the second dose of MMR can be given as early as 28 days after the first dose. Herd immunity threshold is a concept that's used in vaccine programs to give a sense of what threshold is needed of immunization in the community to achieve elimination and reduce endemic transmission of a pathogen. But the key here to understand is just that the more contagious a pathogen is, the higher the vaccine uptake levels need to be in order to eliminate the disease and prevent any endemic spread and outbreaks. That's seen on this graph here. For instance, for measles, if you have a basic reproductive number of 18, you need about 94% of the population to be immune in order to prevent outbreaks and endemic transmission. And Unfortunately, there have been declining vaccination rates, the MMR vaccine that we've seen all over the country. This figure here from CDC is showing the MMR vaccine uptake rates at kindergarten entry grouped by state. First here in 2013, 2014. And this figure, blue represents 95% or more having received the vaccine, which is the target that we set to try and achieve that herd immunity threshold. And you can see how most states did meet this threshold back in 2013, 2014. But when we look at the data from 2023, 2024, now only relatively few states have met that vaccine threshold, which is making the population more susceptible to the possibility of measles outbreaks. And in fact, now we can show the data for what's happening with measles outbreaks in 2025. Again, this will change frequently, and you can go to the CDC website to keep track of measles outbreaks and how these are changing over time. Notably, in Texas here, we have had our largest measles outbreak in over 30 years. There have now been over 400 cases of measles detected in Texas. The outbreak started in West Texas, but has been spreading outward and has also spread to other states like New Mexico, Oklahoma, and an outbreak in Kansas that might be related as well. There's now also an outbreak of measles going on in Ohio, and several imported cases of measles have been detected in up to 20 different states now across the country so far this year, with a few different ongoing secondary transmission cases. And so we are on pace to potentially have the most measles infections in a year in the post-elimination era in the United States. Okay, so that's where we are with measles. So how do you recognize and diagnose measles? The keys to diagnosing measles are really the basic fundamentals in medicine. It's history and physical. And the rash alone isn't always going to be a indicator that you need, because there are mimics and things that could look like measles. And so you really have to consider three different things when evaluating someone for measles. Now, first is the signs and symptoms. And these are fever, cough, coryza, conjunctivitis, and rash. The pathognomonic ananthem that are called Koplik spots, which we'll go over these shortly. There's a very classic timing of symptom onset and quality of the rash as well that I'll go over in the upcoming slides. But in addition to that, you want to think about what potential exposures this person could have had to measles. Have they traveled to an area that has endemic measles transmission where measles has not been eliminated? Are they living or have traveled to an area where there's an ongoing outbreak, perhaps even in the United States? Or are they reporting a known exposure? Either they specifically know that they were exposed to measles, or the health department or some health authority reached out to them to tell them that they may have been exposed. And then we have to consider the susceptibility, because anyone who's had a history of measles infection, and the vast majority of people with a history of measles vaccination do have permanent lifelong immunity to measles and are very unlikely to have measles infection. So consider these three factors when evaluating someone for measles. The classic progression of symptoms is demonstrated in these charts here. After about a 10-day incubation period, patients will start to develop fever, cough, and cold symptoms like congestion and runny nose. These symptoms will progressively get worse over the next few days, and they'll usually also develop conjunctivitis or red eyes. The length of this prodromal period can be variable, but usually lasts at most around 4 to 5 days, and then peaks where the fever gets really high, up to around 105 Fahrenheit, around the same time that the rash first emerges. And the rash then lasts about 4 days or so, and then convalesces. So if you see a patient who had rash precede the fever, that makes it very unlikely to be measles. So going into these different phases with a little bit more detail, and we'll show some images on the upcoming slides. The prodromal phase is this phase before the rash appears. And this is it starts with a fever that gets progressively higher throughout this phase, and some upper respiratory infection symptoms like cough, rhinorrhea, and conjunctivitis. The conjunctivitis may not be present till late in this phase. One thing to note, though, about measles is that these symptoms are usually quite prominent. They're not very mild. The cough can be very severe. The rhinorrhea causes it can be so profuse that it causes inflammation of the nasal mucosa, and the conjunctivitis also can be quite prominent. And the pathognomonic ananthema that we talk about in measles, or internal rash, Koplik spots, these can develop late in the prodromal phase and are often, if you do see them, the best clue that you could be seeing a measles patient even potentially before the rash has been present. The Koplik spots are these well-defined erythematous spots that can be present on the palate or the buccal mucosa. They can have a central discoloration where they're lighter, like whitish or bluish in the central spot. But the lesions are not petechial, they're not exudative, they're not ulcerative. So here's an example of Koplik spots on the palate of a patient. You can see these erythematous lesions. This is an example where on the palate, they're not always having this sort of central whitish or bluish discoloration, at least not very prominently. And here's an example of them on the buccal mucosa, where you can see some of these lesions. I think that with some of these pictures of Koplik spots where you have the flash on the camera, it can make it a little bit harder to see. But if you do spend a little time looking here, you can see some of these lesions do have this erythematous border, and then this central whitish or grayish color here, indicating that these are Koplik spots. After that, the rash phase occurs, and here the rash typically begins as flat red spots that appears on the face, often all the way at the hairline, and then it spreads cephalocaudally or downward to the neck, trunk, arms, legs, and feet, and includes the palms and soles, which is one of the few rashes that can involve the palms and soles. The rash is typically macular or maculopapular, so it's either flat or it can be flat with occasional raised lesions. The spots may coalesce as the rash spreads, and so some of the smaller spots may start to look like larger reddish regions. And as I mentioned, the fever typically spikes when the rash first appears. Now, some patients who are either immunocompromised or who actually have breakthrough infections after vaccination can have more atypical presentations where the rash either is not as prominent or is absent altogether. But these are, for the most part, uncommon presentations. Here's an example of a measles rash on a patient's extremity, and all of these images are available on Visual DX for review in the future. So these here, you can see this disseminated maculopapular rash with most of these lesions looking flat, with a couple of them looking a little bit raised and not really sparing any area of the body. This is another example of the rash here. You can see it on a patient's chest and upper extremity. Again, the rash here is becoming so prominent that it is coalescing in some areas. This is another example of the measles rash on a patient's back with a few more prominent maculopapular lesions. Here we can see the measles rash on a patient's forehead, and notably this, if you're seeing the disease early in the process, it usually looks most severe on the face and forehead area, because that is where the rash typically starts. Another example here of the macular rash that is coalescing in some areas into larger red spots. This is an important image to see, where you see it sort of classically here in an infant who is infected with measles. In addition to seeing how diffuse this rash is and how prominent it really is on the face on this image, also want to highlight, you'll see the bottom of this patient's eyes and see the patient's mouth, and you can tell that this infant is quite uncomfortable and looks very ill with this infection. That is a classic thing with measles, so you should not expect the patient to just have a rash but then otherwise look happy and be running around and bouncing up the walls. Patients with measles have a rash and then also look quite ill. Their eyes are red, their nose is runny, and they are very fatigued and sometimes can be at risk for dehydration. Measles on people with darker skin tones, sometimes the lesions aren't quite as red. They can be a bit darker in nature than red. So even if you're seeing a lesion that isn't like a bright red lesion, you still want to consider it, especially in somebody who is a person of color. Here's another example of the measles rash up at the hairline. And again, the measles rash on a patient's face, showing how prominent the lesions can be. Again, highlighting with the measles rash that this is a macular or a maculopapular rash. If it is a vesicular rash or pustular, then it is not measles, and to consider alternative diagnoses. After the rash resolves in 3 to 5 days, you typically enter a convalescent phase, where the classic description is the rash fades from red to copper to brown in the same pattern that it first appeared. And then a fine desquamation can occur, but there is no permanent scarring usually. There are some alternate presentations of measles to be aware of. There's this modified measles that I kind of mentioned earlier, where they don't necessarily have all of the classic symptoms of measles, and sometimes the symptoms can be a bit more prolonged. And then there's also an entity that's called atypical measles that really refers very specifically to a group of people that got a killed measles vaccine that was available in the early to mid 60s, and then subsequently developed measles, where they get atypical symptoms. The rash is yellowish, and they can develop systemic symptoms like abdominal pain and joint pains. But this should be quite a rare occurrence now, as that vaccine has not been around for nearly 60 years. People who are at highest risk for complications include children under 5 years old and adults, pregnant women, those who are immunocompromised, and those who are malnourished, especially those with vitamin A deficiency. And common secondary bacterial infections can occur, such as otitis media, diarrhea, pneumonia, and then the virus can lead to encephalitis. And sometimes, in very rare presentations, you can get a hemorrhagic measles, which almost looks like a DIC, could be confused with meningococcemia. And then subacute sclerosing panencephalitis, which is a neurodegenerative disorder that occurs rarely, but several years after measles infection. About 1 to 2 out of every 1,000 people with measles die from the infection. So how to evaluate a patient should you have clinical suspicion for measles? The CDC has this flow sheet available. I'm not going to go through this whole flow sheet right now, and this is available in the slides, and you can find this on the CDC website as well. But the thing, again, to highlight is the 3 things to consider are the signs and symptoms, the exposures, and the immune status of the person. Measles is typically in low incidence settings. To try and diagnose this, you want to use a combination of PCR tests and serology. And so the PCR is usually a respiratory swab that it's recommended to be a throat or a posterior pharynx swab, although nasopharyngeal swabs can be used too. You would use the same equipment to do this as you would to do PCR testing for other respiratory viruses like flu or RSV. And serology, the IgM from blood, can be used to confirm acute infection. Like most viral illnesses, the management of measles is predominantly supportive care. There's been no proven antiviral therapy that helps patients with measles. There's pretty good evidence that vitamin A deficiency interacts with measles in the sense that it gives patients a much higher risk of complications and mortality. And because of this, and because of some studies that have been done internationally with the WHO, they do recommend vitamin A, high-dose vitamin A for all patients with measles. In the United States, though, where vitamin A deficiency is not as common, technically the recommendation that we have is to give vitamin A to all patients with measles. Although often when we're giving recommendations, I would recommend this for patients with severe enough disease to be hospitalized, with all who have suspected vitamin A deficiency or malnutrition, and then only consider it for those with more mild cases that are being treated as an outpatient. Vitamin A, though, does not prevent the acquisition of measles. It can modify the severity of the disease. And no other alternative therapies have been proven to improve outcomes in patients with measles. We define evidence of immunity to measles as having documentation of age-appropriate vaccination with the live measles vaccine, having laboratory evidence of immunity, laboratory confirmation of prior infection, or anyone who was born before 1957. Severely immunocompromised individuals may not be considered immune regardless of their prior vaccination status or prior infection. So if you are one of these individuals that may have an immunocompromising condition, you may want to discuss it with your physician whether you really would be under this category of severely immunocompromised in regards to your immune status to measles. Those who are non-immune to measles who get exposed can be given post-exposure prophylaxis. If this is within the first 72 hours and you are not contraindicated to getting the live virus vaccine, we would give MMR. If it's any other time in the first 6 days, or if you have a contraindication to getting MMR, the immune globulin can be given either intravenous immune globulin for most larger people and IM immunoglobulin for young children and infants. So how do you prevent measles in healthcare settings? There's several strategies that you can use here. One of the most important is making sure all healthcare workers are immune to measles. So you want to make sure all healthcare personnel document immunity to measles prior to employment. Although those who have an exemption or who are immunocompromised should not see patients with measles, even if they can wear the appropriate PPE. Those people should be excluded from seeing patients with measles. Being able to identify measles quickly to get patients out of waiting rooms or other areas where they could spread the virus is very important. And so you need to think about how you're going to screen patients for measles. Ideally, this can be done in the pre-arrival setting where you can have patients call ahead, or the clinics can call ahead to identify who may have measles. You can try to use electronic screening like what may be available in the electronic health record. If you're getting a transfer to another facility, or if you're sending one to another facility, make sure to include any concern for measles in the transport information. And now is the right time to consider a protocol of if this such a patient was going to come in, how would you handle them? Do you have like an alternate entrance to your ED that you can bring them in? Try the key here again, making sure that they're not in a waiting room or a common area at all. And then you also want to screen people upon arrival for any measles exposures, travel to measles endemic areas, and symptoms of measles, and especially fever and rash. Once you have concern that a patient may have measles, you need to immediately isolate them. Yeah, provide that patient and anyone that's with them with a face mask and move them out of a common area, such as a waiting room, and get them in a single patient room with a closed door. Ideally, you want to use an airborne infection isolation room or a negative pressure room if one is available. But if one is not available, you still want to get them to a single room as quickly as possible. These patients should be managed on airborne precautions, which means, again, they ideally would be in an airborne isolation room. All healthcare personnel must wear an N95 or equivalent respirator, even if they have documented immunity to measles. A regular face mask is not going to provide much protection at all against measles. You do want to consider transfer to another facility if you do not have an airborne isolation room available, but please discuss this with local health authorities before doing that. Airborne precautions are recommended until 4 days after the rash first appears. And then standard cleaning and disinfection procedures are important and useful for measles. So whatever disinfectants you're normally using to turn over rooms are active in killing the measles virus. Additionally, you want to encourage some baseline things like respiratory hygiene and cough etiquette, having the patient wear the mask whenever they're not in a room, and limiting patient transfers. If healthcare personnel are exposed to measles, if you are immune, there is no work restriction recommended. You should just monitor for symptoms for 21 days. If you're not immune, first, you should be identified to be administered post-exposure prophylaxis, but then under the guidance of local health authorities, you will be recommended to have a work restriction from day 5 to 21 after an exposure, which is obviously not convenient for individuals or healthcare systems. Any healthcare personnel who does have known or suspected measles, though, would be work restricted until 4 days after the rash first appears. So that was quickly going through a lot of measles information, how to identify it, how to keep everyone safe. Thank you so much for your time, and now I'll be happy to answer some questions.
Great. Thanks, Zach. As we look to them, I want to augment some of the great knowledge that you just shared. We're not all infectious disease docs here, and I'm thinking of, as a busy ED doc myself, I learned from your lecture, and so did some of my colleagues here. And I'm really excited to share about this important partnership between ASAP and Visual DX, which is a powerful visual clinical decision support tool to help address this outbreak. Thanks to ASAP, all members will get free access to Visual DX for the next 2 months. I'll put a QR code on the screen and put it in the chat. You can go to asap.org/visualdx or scan the code to get it started. The partnership comes at a very critical time. Again, credit to ASAP for doing this. As a Visual DX user myself, I've seen firsthand how it's a need to have for at Penn in the emergency department for any visual appearing disease. And I'll show you how how I personally use it. Don't hesitate while I'm doing a quick screen share, just a minute or two, on putting stuff in the QA. And again, thank you to Dr. Most. So right now, on screen share is a 2-month complimentary access for Visual DX. Your institution, you might be lucky like me at Penn. I have access to it. We use it all the time. If you don't, no big deal, because as ASAP members, you now have 2 months free, so you could scan the code right here. Just asap.org/visualdx. If I'll put this in the chat as well. You just log on, excuse me, to ASAP, and then you'll have access to this as well. Last thing I want to show you is, if you're unfamiliar with what Visual DX is, it's like this. I'm not a Dr. Most. I'm not an infectious disease specialist who has all the background and the knowledge and this kind of stuff. Like I was saying at the beginning of the talk, I'm busy during my shift seeing chest pain. I saw a stab wound while I was taking care of a stroke patient yesterday, and an ESI-3 rash came through. If I remember most of, but not everything what Dr. Most told me, and it's 3 months from now, and we're starting to see measles cases in the Philadelphia EDs, like, what am I supposed to do? I'm busy and that kind of stuff. I personally, this is how I would do it, and you'll have access to this. You go, let's say in the next 2 months, you go to visualdx.com, you do diagnosis lookup. Let me make sure my screen share is going. Excuse me for 1 second. There we go. Okay. Then, very easy to use. You look up measles. If this is higher on your differential, you're not sure. Here's a lot of the same stuff Dr. Most just covered. You have you have high quality images here. Really, the most of anything that I'm familiar with by any resource. Like I use UpToDate certainly, as I think a lot of my colleagues do. But when I read about a maculopapular rash that spreads downward after about 7 to 10 days of symptoms, and it could be palms and soles, it may not be, but it's one of the few. My mind's eye has trouble picturing a lot of that stuff. But I know what room 17 in the ED has. I know the rash that they may have. That's what's really nice about using this software, is that you could click through. These are high quality images. If your patient's black, you could click here, and it just shows patients with skin of color. Or it's really nice in that it aligns what you may see in the ED with what are considered, I think, very good resource. Easy to use article. And then it even has a differential, because I might be thinking I see measles, but I'm actually seeing something else here. It might actually be parvovirus B19. And again, I'm an ED doc. I'm trying to figure out between measles or parvovirus. That might be hard. And it's nice to have a good resource such as VisualDx for this kind of thing. So that's all I have for how I use it. It's easy. There's a phone version. It's free right now. Thanks again to ASAP. And so I'll put the link in the chat. And Dr. Most, why don't I read out loud, if it's okay, some of the QA stuff, and then you weigh in as the local expert. So the first question, and I certainly have seen this myself, how do we differentiate complex spots on the palate that are also associated with a similar sort of visual presentation in someone with acute streptococcal pharyngitis?
That's a great question. And sorry, before I answer that, just to echo what Dr. Moon had said, as an ID physician, I'm also not a dermatologist, right? And I use Visual DX as a resource myself all the time to help me distinguish different appearances of rashes and make sure that I'm thoroughly thinking of the differential diagnosis for any kinds of rash that I see. So it's really just echoing that point. And so, distinguishing complex spots from petechiae, things to consider, that the petechiae will look more hemorrhagic, are often going to be smaller, maybe darker in color compared to complex spots, which are more of a brighter red and shouldn't really have a hemorrhagic appearance to them. But I will say, even to the most astute eye, the sensitivity and specificity of using complex spots to diagnose measles is really not as good as you might think. So while it can be helpful to make the diagnosis, it's not always perfect, because it can be confused with other things.
So Dr. Most, this is what some ED folks might do. I'm not saying this is right nor wrong, but you see someone who you say, maybe that's strep pharyngitis, maybe this person with their unique history has measles. Would it be unreasonable to test for both? That is, a rapid, so what you have access to, we don't have access to everything in the ED, a rapid strep test on that patient, as well as some of those diagnostic measles tests?
Yeah, I mean, a couple things to consider. As I mentioned in the presentation, considering measles, you really should go beyond just the symptoms the patient has and consider, do they have a plausible exposure to measles, and are they immune to it? And so if you are worried that this patient has measles, then for sure you should test them for measles. But that also then comes with making sure you have them on the right isolation. You may have to shut down the room the patient's in for a period of time afterwards. And so, be aware that there are certain, I wouldn't want to cast too wide of a net for testing people for measles. But certainly, if you remain concerned based on those three criteria that this patient does have measles, then I would recommend testing for them, even if you're also testing for something like streptococcal infection.
Sure. All right. We have a question about how much immunity is real. Immunity, it's not always just binary, you're immune or
Yeah.
not. And so the question is for those who have immunity, are you still able to catch and spread measles among non-immune folks?
So the vast majority of people with measles do have a rather binary immune or not immune, and those are the vast majority of people will be immune. They will not really be able to catch measles, and they're definitely not able to spread it at all. There are some people that will have been vaccinated who aren't immune and can still have vaccine failures and potentially get the infection. So that's a small percentage of the people who have been vaccinated, but that is a possibility.
Um, Another question. This is a ED sort of operations and patient flow
Yeah.
challenge. And you gotta imagine, as I'm sure you know, Dr. Most, many ED waiting rooms are bursting. And so as soon as a room, patient's discharge or goes upstairs for admission, we like to turn those rooms over, but in a safe way. So if a patient, let's say a potential measles case was in the ED and they were in a room that does not have negative pressure, which is true. So I'm at Hospital University of Pennsylvania. I've been there a decade. It's a brand new ED on top of it. And we don't have negative pressure in all of our rooms. And of course, we still use hallway beds. So if a patient was in a room that does not have negative pressure, how long is the virus sort of, quote, in the air? And another more practical question is what do you do to make that room usable again in the setting of a busy waiting room? How long does it remain empty for?
That's a great question. I mean, the simplest answer is if you give it 2 hours, you'll be pretty safe at that point. And the general recommendation is a maximum of 2 hours will be needed to clear the virus from the air safely. The more in-depth answer is it depends on how many air changes per hour your room is getting. And the CDC also provides a document that shows how much air changes per hour you need, and then how much time you need to remove enough particles from the air to make the room usable again. So for instance, if you're using like a negative pressure room that has 12 air changes per hour, that can be reused usually in about 35 minutes or so. Whereas a room that's getting poorer ventilation might need 2 hours. So if you want to get in touch with local engineering teams to get a sense of what air changes per hour are in your area to come up with a plan to minimize the amount of time that you need to hold off using those rooms, you can go ahead and do that. But if that's not available or you don't know for sure, the recommendation would be to go 2 hours before reusing the room.
Thank you. All right. Before we start, I told Zach, I said, you're going to get a bunch of sort of personnel questions, and that's exactly what we're seeing here. These are great questions. So I'm going to just read out loud from one of our colleagues, from Tom Brunel. I had exposure to measles about 10 years ago. I think Dr. Brunel intubated this patient who had measles. There was no PEP. Measles was discovered later on. Of course, by the way, anecdotally, they don't come in with the diagnosis. They're in respiratory failure. We're doing ABCs. I have had to have my measles, IgG, IgM checked. I was vaccinated as a child. Infectious disease required recheck of my IgM, IgG, and I had 4 consecutive MMR vaccines over 5 years and was determined to be a non-converter. I have been exposed since, not recently, and my current infectious disease physician believes I do have immunity that does not show up on the immunology assays. How common is this? Should I be rechecked? And you can imagine, as you're thinking about that, I know that's a long question, Zach. There's other ED docs who have had similar type thing, maybe anesthesia and ICU as well. I've been very exposed, but I was vaccinated before. And how long do I keep checking for?
Thank you for that question, Dr. Brunel. And I guess what I can say is more generally, there are aspects to immunity that go beyond just your IgG level. And so typically when people have had the full recommended vaccine series, we don't routinely recommend checking antibody levels to prove that they're immune. Certain circumstances, like if you were immunocompromised or such, you may do that. But if you have received your 2 doses of, especially if you've gotten 2 doses of MMR vaccine, you're typically considered immune. Now, obviously, I mentioned there are some small proportion of people who, despite 2 doses, will not technically be immune. But as you point out in this question, just checking your immunoglobulin level doesn't necessarily confirm one way or the other. Looking at someone's immunity to a specific pathogen is a very complex topic, and there aren't necessarily good tests to always determine that. So really, the best thing you can do is what you've done is get your vaccination, and stay up to date with vaccine recommendations.
Great. Breathe a sigh of relief in a lot of those settings. Looks like our final question is from Mark McMullen. This is again picturing as an ED doc, should we have a higher or lower or a changed threshold for admitting these types of patients, or the same as anyone else? If we are electing to discharge someone, what specific discharge instructions should we be providing these patients?
Thank you for this question, Dr. McMullen, because it's a important topic. Some providers, especially when they're uncomfortable with measles or haven't seen it a lot, and are hearing about the complication rates a lot, have a preponderance to want to put people in the hospital when they have measles. That the criteria for admission for somebody with measles should be the same as anyone else that you're seeing. And if this is like a child in particular, who are most likely to get measles, we're thinking a lot about respiratory distress, dehydration, altered mental status, anything like that. And so those criteria should not change just because one has measles. So I would definitely say you do not need a lower admission threshold than somebody without measles. Now, should you have a higher threshold, as you point out, because of the secondary infection risk to others potentially in the hospital, I can't routinely recommend and say that you should have a higher threshold. You should really be using the same threshold for admission for anyone else. But I will say more anecdotally, in our infection control experience here at my hospital, we are trying to advocate to get measles patients or other kinds of contagious patients out of the hospital as quickly as possible once they're safe to do so. And the other part of the question was asking about discharge instructions. That also highlights, before I say specifically about discharge instructions, pointing out that in all states, even with suspected measles is a notifiable condition to health departments. And so you should either be notifying your health department, or if you have a policy with your local infection control group, that maybe the infection control notifies the health department. Just make sure to work that out. And certainly I would follow any sort of guidance that the local health authorities have given that should be relayed to the patient. In general, though, patients with suspected measles should be told to isolate at home until the earliest of either 4 days after rash onset, if their testing results come back negative, or if they're contacted later on by a health authority who tells them that they can end their isolation.
All right. Well, I want to once again share information on how ACEP members can access their free 2-month access to Visual DX. You go to acep.org/visualdx and sign in with your ACEP credentials. I'll put up the QR code. And again, big thank you and shout out to ACEP for this partnership, and to Dr. Zach Most for your educational presentation. Thank you very much, everyone.